in order to join everyone.
Yes, yes, of course, of course.
Okay.
Okay, is it time to start, colleagues?
Yes,
Or we
please.
wait? Or
Yes,
shall we
let's
wait?
start and the others they will join if they
Hmm?
want. Let's start and then if they
Okay,
want they will.
okay. We start. We continue, in fact, with the immune deficiency states because any loss or improper function of the various components of the immune system lead to immune deficiency. They can occur in any part or state of the immune system, and in any of the participants, physical barriers, all the cells that participate in the immune system. So the immunocompromised host has an impaired function of immune system and is immediately at high risk of infection. As you can see, the biggest percentage of these immune deficiency states in children are secondary. They are due to some underlying disease. Only a small percent, around less than 10%, in fact, are intrinsic, primary or intrinsic, and they are connected with different etiologies, missing enzymes or missing some cell type or non-functioning components. They are congenital and they manifest since very early age, immediately after birth in most of the cases. While the secondary, you see they are due to some malignancies or infections, malnutrition, and immunosuppressant drugs. They are acquired and they can manifest in any age. I'm sorry, but I have some problem with changing the slides. Mm, I have.
If you exit from the full screen,
Yes, I try. Yeah.
yeah,
Now,
now it's
here
better.
are all the heroes, the cells that participate. Already we talked about them, natural killers, cytotoxic, and all others kind and subdivisions of cells. So we start with the barriers, the first line of defense, the integrity of the anatomical and mucociliary barrier, we mean skin and mucous membranes, is essential for protection. The anatomical and mucociliary defects in respiratory systems are very important. In the upper ways, we have the aspiration syndromes like gastroesophageal reflux and foreign bodies. We'll talk after 2 weeks. We start details about respiratory system and we'll talk about all this. Some anatomical defects like cleft palate or dysfunction of the eustachian tube, hypertrophy of adenoids, nasal polyps, obstruction of paranasal sinus drainage, encephalocele, or any post-traumatic or congenital sinus disorders. You will see some anomalies of sinuses and so on. All these defects can lead to immunodeficiency state. In tracheobronchial tree, the tracheoesophageal fistula, pulmonary sequestration and bronchogenic cyst, you'll have the details later. Some vascular rings that surround sections of respiratory systems and make some compression, tumors, foreign bodies, enlarged lymph nodes, and primary ciliary dyskinesia syndrome, physiologically defects already, cystic fibrosis of the pancreas, a chronic disease, bronchopulmonary dysplasia in neonates and small babies, bronchiectasis, allergic disease like rhinitis and asthma, and very important, the chronic cigarette smoke exposure of children. I know, unfortunately, in Bulgaria, many young families who smoke non-stop in the presence of children. Some other defects like burns, the chronic atopic dermatitis. It is twisting the function of the skin, ureteral obstruction, vesicoureteral reflux, artificial heart valves, although nowadays, they are very, very good, there is very good production, and we don't see the older complication after um, transplantation of new valves. In cases of cerebrospinal fluid shunt in hydrocephaly or some other disease, peritoneal dialysis catheter. You have this here on the image of this. We have children with peritoneal dialysis catheter, urinary catheters, and intravenous drug use for a long period of time. All this can cause defects on the outer barriers. Here is the long list of secondary immunodeficiency, different causes. They are grouped in viral infections. HIV virus destroys especially the T cells that are marked like CD4, measles, rubella, influenza, many of the metabolic disorders like diabetes mellitus, malnutrition, uremia, sickle cell disease, zinc and vitamin deficiency, and the cases of multiple carboxylase deficiency, burns once again, states with losing protein, nephrotic syndrome, protein losing enteropathy. Other causes may be prematurity, some immunosuppressive agents, corticosteroids or radiation, antimetabolic malignancy, especially lymphomas, Hodgkin, leukemia as well, non-lymphoid cancer, the acquired asplenia, post-traumatic or because of we don't have we see rarely in children hypersplenism like in older people. You can have this as a cause for splenectomy, but usually in children it is more associated with some traumatic trauma incidents and accidents and so on. in stem cell transplantation, the graft versus host disease, and all the autoimmune disease like lupus and all the other, and sarcoidosis. The diagnostic evaluation, just in few words, uh, depend on early recognition of signs and symptoms of primary immunodeficiency. From the anamnesis, we seek history of recurrent severe infections from early infancy or some familial history of the disorder, but the most important are the laboratory tests that will evaluate the immune function. And now we continue with primary immunodeficient conditions, a kind of classification. You know that immunology is developing very quickly and successfully. So we have almost each month we have new disease, new causes found, and many of the old names are changed because we know already the exact mistake in the gene or something of the kind. So they are grouped in prevalence of antibodies deficiency, and here we have the sex-linked agammaglobulinemia, sex-linked agammaglobulinemia, and growth hormone deficiency. Autosomal recessive agammaglobulinemia, not connected with the Higgs chromosome, selective immunoglobulin deficiency. We may have different cases with elevated level of IgM and IgD, IgA deficiency, which is not rare, selective deficiency of other isotypes of immunoglobulins, the kappa chains deficiency. These are the light chains of the immunoglobulins. Immunodeficiency on the background of thymoma, transitory hypogammaglobulinemia in children. Another group are the combined immunodeficiency. Very well known are total variable immune deficiency with primary antibody deficiency or primary deficiency of cellular immunity. Then the severe combined immunologic deficiency like reticular dyskinesis and deficiency of T and B lymphocytes. It was known earlier like the Swiss type of combined immunodeficiency states. T lymphocyte deficiency, the early Nezelov syndrome, deficiency of some enzymes like adenosine deaminase, purine nucleotide phosphorylase deficiency. Then we have the absence of HLA in Bulgarian, HLA antigens of the first class. This is called the syndrome of naked lymphocytes. They don't have the receptors for this antigen first class. Or then we have the absence of for the second class of the human leukocyte antigens. Then the third group is immunodeficiency in combination with other congenital defects. Also well known are the Biscott Aldrich syndrome, ataxia telangiectasia, the Lewy-Bodies syndrome, the syndrome of the third and fourth pockets of branchial arch. This was formerly known as DiGeorge syndrome. Deficiency of transcobalamin, immunodeficiency due to congenital anomalous reaction at Epstein-Barr virus. This is maybe in the recent years is well studied. This immunodeficiency due to congenital anomalous reaction at the virus of Epstein-Barr, it may be and usually is fatal in almost 80% of patients. You will see some details later. So you have these three big groups. And in general, the clinical manifestations, the most common of them are or is in fact the susceptibility to infection early in life. Most often they develop by the 3 months of age, and they are characterized, these infections, with chronic evolution, failure to completely recover from an infection, then come the frequent reinfections. They are infected with unusual agents, unusual for the age, and history reveals no logical source of infection. These are the most important characteristic, clinical manifestation, and some clinical characteristic depending upon the defect. For instance, in B cell defects, we have recurrent pyogenic infections with extracellular encapsulated organisms such as Streptococcus pneumoniae, Haemophilus influenza type B, and group A Streptococcus. They develop otitis, sinusitis, recurrent pneumonia, bronchiectasis, and conjunctivitis. They have a few problems with fungal or viral infections, except enterovirus and poliomyelitis. Poliomyelitis viruses is in the same group of enteroviruses. Diarrhea is common, especially secondary to infection with Giardia lamblia. Minimal growth retardation. They develop, well, survive to adulthood or for several years after onset unless some serious complications occur. The T cells defect, also recurrent infections with less virulent or opportunistic organisms such as fungi, candida, mycobacteria, viruses, protozoa, as well as bacteria. They have growth retardation, malabsorption, diarrhea, and failure to thrive. All are common characteristics. Allergy, susceptible to graft versus host disease from non-irradiated blood or from maternal engraftment. Fatal reactions may occur from leaf virus or the bacille of Calmette-Guerin. If we vaccinate with BCG vaccine, may have fatal reactions in T cells defect. So immediately after birth, when we start in Bulgaria, especially, we start the BCG vaccination on the second day after birth, we should be absolutely sure that the child is well and there is no suspicion for some immune deficiency like T cell defects. There is very characteristic, increased incidence of malignancy. Remember, this is especially with T cells defects. And poor survival beyond infancy or early childhood. In neutrophil defects, there are recurrent dermatological infections with bacteria such as Staphylococcus, Pseudomonas, it is not usual at that age, Escherichia coli, and fungi such as Aspergillus, not Candida. Subcutaneous lymph node, lung, and liver abscesses, common pulmonary infections, including complications like abscess and pneumatocelie formations that contribute to chronic disease. Bone and joint infections are common. Very characteristic may be the delayed separation of umbilical cord, sometimes up to the second month after birth, but with omphalitis as well, and some other complication. You will see next lecture is on newborn babies. You will see omphalitis, and you will remember that the delayed separation of umbilical cord is usually connected with some neutrophil defects in the neutrophils. Very characteristic absence of pus at sites of infection and poor wound healing. Defects in complement demonstrate recurrent bacterial infections with extracellular encapsulated organism, such as Streptococcus pneumoniae, Haemophilus influenzae. There is susceptibility to recurrent infections with Neisseria meningitidis, increased incidence of autoimmune disease with complement defects, severe or recurrent skin and respiratory tract infections. The most important laboratory tests. We need a complete blood count with differential formula, serum albumin and levels of immunoglobulins, the specific antibody titers, phenotyping of lymphocytes, which is done by flow cytometry, very useful method. Some special tests in specialized research laboratories like cytokine synthesis, intracellular signaling pathways, or expression of activation markers, assay of complement, tests for neutrophil function, the elevation of neutrophil phagocytosis or chemotaxis and bacterial killing. They are also done in specialized laboratories, but they are well-known tests, well-developed. The delayed type of hypersensitivity, of course, we need genetic testing, and the diagnostic images, either X-ray of the chest for revealing the thymus, or if needed, computer tomography or some other image diagnose. The isolated B-cell disorders result in antibody deficiency disease. T-cell disorders usually cause combined immunodeficiency. A-gamma globulinemia results from the absence or defective function of B cells, with subsequent severe decrease in immunoglobulin levels and absence of the specific antibodies. I will give you some details, just the most important to remember about some very well-known disease of immune deficiency. The first one is the Hex-Linked A-gamma globulinemia. It is called also Bruton A-gamma globulinemia. It was described by this Dr. Bruton. Affects only males, of course, and this is a failure of B lymphocyte precursors to mature into B lymphocytes and ultimately to change into plasma cells. So we have deficiency of B cells, severe hypogammaglobulinemia, and absence of lymphoid tissue. Here I found a case of this small baby that presents with recurrent otitis and areas of cellulitis in the diaper area. You see If this was only red, we can talk about intertrigo, but you have here, you see, you have a more serious lesions with cellulitis. Pseudomonas aeruginosa and Staphylococcus. Staphylococcus is usual for this age, but Pseudomonas not. Pseudomonas and Staphylococcus are isolated from the skin lesions, and then the child developed hemolytic anemia and neutropenia. They were confirmed that are autoimmune because autoantibodies were found in the laboratory tests. So, a generalized picture of clinical presentation of autoimmune anemia and neutropenia and all these changes, infections of the skin. A boy. It is not well seen here, but it should be a boy. Here you have two brothers in a with milder symptoms of agammaglobulinemia linked with a Hex chromosome. It is at first it was diagnosed in the small younger brother when he presented with neutropenia and typhlitis. Typhlitis we call the neutropenic enteroculitis. Typhlitis. And after he was found to have this gene of X-linked agammaglobulinemia, these changes in the X chromosome, the older brother, who looks quite well, you see, but he had a history of 7 episodes of pneumonia. It was evaluated and diagnosed also as the Bruton agammaglobulinemia linked with the Higgs chromosome. In both brothers, the B cells with the biomarker CD19 were less than 1%, which is a finding consistent with X-linked agammaglobulinemia. There is an autosomal recessive form. When compared with the previous, it has an earlier onset of disease and more severe complications. Females may develop the disease with early onset infections, profound hypogammaglobulinemia, and absent B cells. Male patients with negative BTK mutation analysis results. The common variable immunodeficiency. It is a heterogeneous disorder characterized by hypogammaglobulinemia developing after, it's quite strange, after an initial period of normal immune function, and most commonly this happens in the second and third decades of life. So we can have this after 10 years of age and later on after 20 years of age. What is exactly what are the gene defects that lead to the majority of cases are unknown. Patients are susceptible to frequent respiratory tract infections. They develop autoimmune hemolytic anemia and thrombocytopenia frequently, and granulomatous disease affecting the gastrointestinal tract, liver, lungs, and all this leads to significant morbidity. But the major cause of mortality is cancer, especially lymphoma. You see, heterogeneous, too many clinical presentations in different organs and systems. I'm sorry, but we don't have here I can try to find what is we don't have here title of the slide on the left also. This is the deficiency of immunoglobulin A. I'm sorry. The serum IgA levels less than 10 milligrams with normal levels of all the other immunoglobulins, but the diagnosis cannot be confirmed until the 4 years of age, when the IgE levels should reach adult levels. We have this very often, we have seen this in practice, but we confirm only after the 4th year of age. You see, it's quite common, you see, occurs in approximately 1 to 500 individuals. Most of them are asymptomatic, may present with recurrent sinopulmonary infections, sinusitis, and lungs. Sometimes we have IgG2 subclass deficiency, specific antibody deficiency, food allergy, autoimmune disease, or celiac disease. And it occurs very often in families, suggesting an autosomal inheritance. These are selective immunodeficiency states of immunoglobulins, and they occur when the level of antibodies in one or more of the 4 IgG subclasses are selectively decreased with total IgG levels normal. IgG immune deficiency. That is, in fact, an inability to synthesize specific antibody titers to proteins or polysaccharide antigens, and this is the best marker of IgG. The subclass deficiency is associated with recurrent infections requiring always therapy. They do not pass without any therapy. The transient hypogammaglobulinemia of infancy. It is a temporary condition characterized by a prolongation of the physiological hypogammaglobulinemia of infancy. We talked about this. In some patients, sinopulmonary infection is increased. Then we have a specific antibody deficiency syndrome, recurrent infections caused by inability to synthesize specific antibody to polysaccharide, especially polysaccharide antigens, normal IgG levels and lymphocyte numbers and subsets. The Hex-Linked hyper IgM syndrome. This is deficient T cell function due to defects of a special ligand, failure of Ig isotype, switching from IgM and IgD to IgG, IgA, or IgE. Affected patients have normal or elevated serum levels of IgM with low or absent levels of all the other immunoglobulins. The severe combined immunodeficiency is a profound lack of T cell numbers or function and B cell dysfunction as well. Clinical manifestation, failure to thrive from early age, severe bacterial infections, chronic candidiasis and other fungal infections, chronic viral infections, infections with Pneumocystis carini, I'm used to the old name, now it is Girovecci, pneumocystis, and other opportunistic organisms, skin disease similar to eczema, and they are extremely susceptible to fatal graft versus host disease from lymphocytes in blood transfusions. Something more than can be infected by cytomegalovirus positive blood products. So they should always receive irradiated, leukopoor, and CMV negative blood products without cytomegalovirus. The most common form is linked with the X chromosome, and it is caused by mutations in the gene which codes the common gamma chain of the interleukin 2. You see, very special details are known now about these deficiency states. I have some problem with the titles. This is the most common form linked with the Higgs chromosome. The affected patients have no T cells or natural killer cells in the peripheral blood, but have normal numbers of B cells. No, this is not the same form. I'm sorry. I will correct it before sending the lecture to you. So you'll have the exact titles. Ig levels are low or undetectable because there are no the T cells that are marked like CD4 to stimulate, they are needed to stimulate the B cells. The autosomal recessive severe combined immunodeficiency has some characteristic of the Omen syndrome, that is exfoliative erythroderma, lymphadenopathy, hepatosplenomegaly, marked eosinophilia, elevated serum immunoglobulin E, and impaired T cell function. Some of the enzyme deficiency, like deficit of adenosine deaminase and purine nucleosidase, they are toxic products are accumulated, products that are toxic to lymphocytes, like phosphorylase, and lead to severe infections early in life. The Behr lymphocyte syndrome, I mentioned it. This is defect in the transcription factors or genes that lead to the absence of these molecules we talked last time, class 1 and class 2, from the major histocompatibility complex. Lymphoid tissues and B cells may be present, but the T cells with the biomarkers CD4 and 8 are decreased or absent. If the number is normal, none of the T cells are functional because the peptide antigens cannot be presented to the T cells. They cannot recognize because they don't have the receptors for these molecules, class 2 and 1. The DiGeorge syndrome, or it is known also as Catch-22 syndrome because of cardiac, abnormal, thymic, cleft, and hypocalcemia. You see cardiac anomalies, abnormal facies, thymic hypoplasia, cleft palate, and hypocalcemia. It is a fetal dysmorphogenesis resulting in hypoplasia of the thymus, which is required, you remember, for the T cell maturation, the university for T cells. Most patients have a deletion on chromosome 22. and classically it is characterized by hypocalcemic tetany, cardiac and aortic anomalies, increased infections. Most of the patients have partial immune defects with low T cell numbers and function that generally improves with age. You see what a discrepancy. Immune deficiency is improved with age, but if they have the serious cardiac and aortic anomalies and too much increased infections, uh, there is no benefit of this improving. You see here the special phase of DiGeorge syndrome. The ears are low post and they are uh, mal with bad configuration. There is a big distance between the eyes and the hypotelorism. Mouth is open and kind of protruding of the tongue. There is a hypoplastic mandibula, some degenerative stigma in this child. Very well known is this syndrome of Biscott Aldrich. It is a disorder also linked with the Higgs chromosome and is caused by mutation of the gene. The, the exact place is known on chromosome Higgs, and it codes for this protein. It is called Biscott Aldrich because they were recently found the gene and all the mutations, and so they were called after the name of these medical doctors that found were the first to describe the syndrome. They were called Biscott Aldrich syndrome proteins expressed in lymphocytes, platelets, and monocytes. The deficiency of this protein results in elevated levels of IgE and IgA, decreased IgM, poor responses to polysaccharide antigens, waning T cell function, and profound thrombocytopenia. The clinical presentations are of eczema, the defects of the cell-mediated and humoral immunity gives opportunistic infections, predisposition to lymphoproliferative disease, and autoimmune cytopenia. I must especially I want to tell you that all these symptoms they do not develop immediately after birth. They follow one after the other, and this is very often seen in all other symptoms and disease in childhood. Sometimes we have the clinical presentations with all the symptoms, but more often they come one after the other. And I remember a boy, I remember his name. He was maybe 3 years when he came for the first time in our clinic with the diagnosis of recurrent otitis. He had every month he had some inflammation of the ears to the right, to the left ear. And we saw at this first time, we saw that he has some changes on the skin, quite a serious eczema on the skin. So he was directed to dermatology to, to take care about the skin. And he continued to come for these recurrent infections of the ear. Maybe 2 years later, he developed a thrombocytopenia with very serious hemorrhagic manifestation. He started with epistaxis, but then he continued to have, we saw the petechi on the lower extremities and so on. And one of our colleagues, Professor Anaduliska, he told us maybe this is the Biscott Aldrich syndrome, but this was long ago. Of course, we couldn't do a very detailed laboratory test. So the parents found the possibility to go to Germany, and he stayed there to be treated. We didn't have at that time enough immunoglobulins, specific immunoglobulins. We produced in Bulgaria was produced the only one kind of immunoglobulin containing only IgG. So he stayed in Germany, and I heard that later he underwent a stem cell transplantation. But what was his evolution later? I'm not sure. You see that 1/3 of the patients with Wiskott-Aldrich syndrome die as a result of hemorrhage because of the severe thrombocytopenia, but the biggest percentage, 2/3, die as a result of recurrent infection caused by bacteria, cytomegalovirus or pneumocystis carini or the herpes simplex virus. The only stem cell transplantation is possible to correct the immunological and hematological problems in some of the patients. Ataxia telangiectasia is caused by a mutated gene on chromosome 11. There are cutaneous and conjunctival telangiectasias and progressive cerebellar ataxia because of the degeneration of the cells of Purkinje in cerebellum. IgA deficiency, IgG2 subclass deficiency of variable severity. I have seen pictures of older people with ataxia telangiectasia, low IgE levels, and variably depressed cell function. Here you have a picture of some children with this telangiectasia in the conjunctiva. Here you have on the ears and on the skin. Cells are exquisitely sensitive to irradiation, so malignancy, including leukemia or lymphoma, can occur. Diabetes also may be present. Sexual maturation is delayed, and there is no effective therapy, only antimicrobial and intravenous gamma globulin help. The chronic mucocutaneous candidiasis. This is a chronic or recurrent candidial infections of the mucous membranes, skin and nails. Genetic defect leads to production of neutralizing antibodies to cytokines important in the control of fungal infections, including interleukin 17. Normal antibody production, but significantly decreased or absent lymphocyte proliferation and delayed skin reactivity to Candida. There is no response to topical antifungal therapy. In early adulthood, they develop autoimmune endocrine disorders like hypoparathyroidism or the Addison disease. You can see here the chronic mucocutaneous changes. This is also the lacking title, but this is the dysregulated immune responses to Epstein-Barr virus, and they were first reported in 1970. That means about 50 years ago. Boys are normal until they are infected with Epstein-Barr virus, which is acutely fatal in very big percent, almost 80%. So you must know that usually children meet Epstein-Barr virus 85, near 90%, they meet this virus up to the 6 years of age. And usually, so they underwent, undergo the Epstein-Barr infection, the mononucleosis, without even sometimes the parents do not understand, like a very easy and infection of the upper respiratory tract. A small percentage of them develop it later, the infection, the mononucleosis later, and they have a more serious clinical manifestations with organomegaly, uh, lymphadenopathy, and even sometimes uh, pharyngeal obstruction because of the hypertrophy of lymph tissues. But as another percent of these children uh, have dysregulated immune responses to Epstein-Barr, and this is due to a mutation of a gene which has its name, you see, SH2D1A at chromosome Higgs, and this gene codes an adapter protein which is involved in the signal transduction of lymphocytes. The clinical phenotype is similar to hemophagocytic lymphohistiocytosis. There is extensive expansion of T cells marked with CD8, hepatic necrosis, and death. Death is due to the last stage of liver dysfunction, insufficiency because of hepatic necrosis. And I have seen two boys in one family, two brothers that died, the two of them in 3 months. This was an awful episode in my life because the first came the older boy who was 8 years of age, very well developed, very good looking, intelligent boy, who came to the hematological clinic with a diagnosis of mononucleosis. But very quickly we understood that this is not mononucleosis, something else. He had, and the situation deteriorated very quickly. And then our professor Bobev, who was a famous hematologist, he decided that this is this syndrome of dysregulated immune response, but we could not, we couldn't diagnosed it because to be sure in the diagnosis we had to find the virus in the lymph nodes, histological testing, but we didn't have this test at that time. So the boy died. Then came the smaller brother who was 5 years of age. He died in the next month. And the most fatal was that after maybe an year and a half, the mother decided to have another, after another pregnancy, she gave birth to a girl, very nice looking, very good, very healthy girl, but at the age of 8 months, she developed a myeloid leukemia. So that absolutely means that in this woman, the X chromosome was quite defect because you see she transferred this disease to the boys, to two boys, and then there was something else, so that the girl, the next child in the family, the girl, she developed the myeloid leukemia. They went to Sweden, and the girl was treated with myeloid leukemia. Is quite bad prognosis. So they waited for transplantation, but we did not heard from them anymore. The hyper IgE syndrome with markedly elevated serum IgE levels. The patients have rash that resembles atopic dermatitis. They have eosinophilia, of course, staphylococcal abscesses of the skin, of the lungs, of the joints, infections with Haemophilus influenzae type B, Candida and Aspergillus. Very characteristics are the coarse facial features. You see all of them, they have these coarse facial features, plus they have joint laxity, osteopenia with fractures, and they develop giant pneumatoceles in the lungs after staphylococcus infections. Some words about general management of patients with immune deficiency. They must be transfused with irradiated and cytomegalovirus negative blood products. They should be prophylactic to pneumocystis carinii when they have T-cell immunodeficiency or this linked with the Higgs chromosome hyper IgM syndrome. For all the T-cell immunodeficiency, we need antifungal prophylaxis. The pulmonary function in patients that have recurrent pneumonias should be followed very strictly. Prophylactic antibiotics, because minor infections can disseminate very quickly, and diarrheal stools should be examined for giardial amblia and Clostridium difficile. You should not remember the the treatment because it differs now according to different kinds. So this recommendation, don't I will treat it. Here is the scheme of stem cell transplantation, which is very easy to be done, but it should be done, of course, in specialized centers because of the need of sterilization and risk of infections. Then we come to neutrophil disorders, quite often in children. They result from deficient cell numbers or defective function of these cells. The normal neutrophil count varies with age, and we talk about neutropenia when the absolute neutrophil count is less than 1,500 in cubic millimeter for white children 1 year of age or older. This is, we call neutropenia an abnormal drop in the blood neutrophil count, which may be due to many different causes like drugs, infections, blood disorders, cancer, or inborn Defects. The clinical effect, will depend on the severity of neutropenia, and susceptibility to infections is minimally increased when the absolute neutrophil count is less than 1000. Most patients do very well with this if the absolute neutrophil count is greater than 500. At these levels, more common are localized infections than the generalized bacteremia. Serious bacterial infections follow when the absolute neutrophil count is less than 200 in cubic millimeter. The types of infections associated with neutropenia are pharyngitis, gingivitis, cellulitis, lymphadenitis, abscesses, either cutaneous or perianal. Perianal, this is a very common site for small children, abscess of the perianal area. Enteritis, and it has this special name typhlitis when it is due to neutropenia, pneumonia, of course, and that you know that the sites of infections usually are colonized with normal bacterial flora, but in the presence of neutropenia, it becomes invasive. Here you have a serious changes in the lung of a patient with mm, neutropenia. Mechanisms may be congenital or acquired. We talked about this due to abnormal bone marrow or something in the peripheral circulation. The infection associated, we have seen very often in bacterial infection, viral infection. We have seen children coming because of low neutrophil count, and on the next morning they have the rubella or measles or varicella, and the drug associated neutropenia may be either cytotoxic or idiosyncratic. Congenital, very well known, is the severe congenital neutropenia or the Costman syndrome. This is an autosomal recessive disorder due to mutation of this special gene, so that myeloid cells fail to mature beyond the early stages of the promyelocyte. They stay at that stage of promyelocyte, early stages. Peripheral blood may show monocytosis, and there is risk from, here you have this girl with acute myeloid leukemia, in those patients who survive into adolescence, they unfortunately may have acute myeloid leukemia, and the only stem cell transplantation may be curative. Cyclic neutropenia, we have seen such children, disorder of the cycle of the stem cell, and it is a transient neutropenia. The usual cycle is, you remember, 21 days for leukocytes, and neutropenia lasts usually 4 to 6 days. It may be transmitted as an autosomal, dominant, recessive, or maybe a sporadic disorder. It is only clinically significant accompanied, neutropenia is the only clinically significant abnormality, and it is usually accompanied by monocytosis, and often we see eosinophilia. I cannot explain why, I couldn't find explanation for this, but when the neutrophil in these periods of neutrophil count is low, they have severe debilitating bone pain. What is the exact etiology? I didn't find anywhere in literature this explanation. Why they complain of such severe bone pain during periods of neutropenia. And the only treatment is to give growth factor, granulocyte colony stimulating factor. You see the lesions on the tongue, gingivitis, very red gingiva. The Schwachman-Diamond syndrome, maybe you have heard about this, an autosomal recessive disease. This is a pan-myeloid disorder in which neutropenia is most prominent, but you have in all the myeloid line, you have some defects. Plus pancreatic insufficiency, because pancreas is replaced by fat, and bone marrow dysfunction. This manifestates either persistent or cyclic periods of bone marrow dysfunction. There is a metaphyseal dysostosis, which explains the short stature and dwarfism, the Schwachman-Diamond neutropenia. Another benign congenital form of neutropenia, it is sporadic, familial, or autosomal dominant disorder. And when the absolute neutrophil count ranges from 100 to 500, there is increased frequency of infections, particularly respiratory infections. And the major problem is the slow resolution of infections that develop. Severe congenital neutropenia may be associated with severe combined immunodeficiency in reticular dyskinesis. That's another disorder of hematopoietic stem cells affecting all bone marrow lineages due to mutation in this special AK2 gene. Reticular dyskinesis is results in complete absence of granulocytes and decreased number of abnormal lymphocytes. Red blood cells and megakaryocytes are not affected. There is also poor development of secondary lymphoid organs, and the cause of this is the inability of granulocyte precursors to form granules because of malfunction secondary to mitochondrial adenylate kinase 2 enzyme. Isoimmune neutropenia. Here you have a slide with plate with the peripheral blood. You see you have maybe thousands of erythrocytes on small magnification, and only one, in fact, here is the granulocyte neutrophil. It occurs isoimmune, it occurs in neonates, and is a result of the transplacental transfer of maternal antibodies to fetal neutrophil antigenes. The mother is sensitized to specific neutrophil antigenes on fetal leukocytes that are inherited from the father, and they do not present on maternal cells. This is a transient process with common cutaneous infections. Sepsis is rare, and intravenous immunoglobulin may decrease the duration of this process of neutropenia. Autoimmune neutropenia usually develops in children between the 5th and the 24th month of age, often persists for prolonged periods. The neutrophil antibodies may be from the three classes IgG, IgM, and IgA, or a combination between them. Usually the condition resolves in 6 months, up to 4 years it may continue, long period, but most patients respond to therapy with granulocyte colony stimulating factor. And in some cases, this autoimmune neutropenia may be early manifestation of systemic lupus erythematosus or all the other autoimmune rheumatoid arthritis or autoimmune lymphoproliferative disease. Disorders in the neutrophil migrations. You know maybe that neutrophils normally adhere to endothelium and migrate to areas of inflammation by the interaction of membrane proteins with endothelial cells adhesion molecules. You have here a detailed scheme. You may look on it. Here another image of the adherence. They are here the endothelial cells and the neutrophils that rolling adhere, and through hemotaxis and diapedesis they contact with the endothelial cells. The hallmark of these defects in migration is the absence of pus at the site of infections. There are three different types: autosomally recessive disorders, and infants lack the B2 integrin and the biomarker with the biomarker CD18 and exhibit the condition early in infancy. Again, we have failure of separation of the umbilical cord, often even 2 months after birth, with this attendant tonsillitis and sepsis I told you about. Cutaneous respiratory mucosal infections occur, severe gingivitis. Sepsis can lead to death in early childhood, and neutrophil count is usually greater than 20,000, but there are defects in migrations. Some other disorders of neutrophil function, they are inherited, rarely, relatively rare disorders, and again you have the susceptibility to bacterial and fungal infections. A special case is the chronic granulomatous disease, which is due to defects of the enzymes activating the catalytic conversion of molecular oxygen to superoxide. And this leads to inability to kill the catalase positive pathogens such as Staphylococcus aureus, cemetery gram-negative bacteria, and fungi. The most common form of the disease is connected with genetic disorder located at chromosome X. Some other gene defects are inherited in an autosomal recessive manner. Here you have this image of neutrophil. If you remember last lecture, the phagocytosis, they reach this stage of forming a phagosome, but that they cannot, the killing mechanism is defective, and the microbes survive. And after that, they form these granulomes. You see here the granulomes in the lung, on the skin, and so on. They have failed to thrive, lymphadenopathy, dermatitis, hepatosplenomegaly, chronic diarrhea, abscesses, hypergammaglobulinemia and anemia, and many infections in the middle ear, lungs, gastrointestinal tract, skin, urinary tract, all over lymph nodes, liver and bone. I don't think and something is spared. Granulomas are prominent and may obstruct even they may do a harmful obstruction of the pylorus or the ureters. The Chediac Higashi syndrome, an autosomal recessive disorder, mutation in a cytoplasmic protein leading to defective neutrophil and natural killer cell function. Giant granules are present in neutrophils, lymphocytes, platelets, and melanocytes. This you see this giant. This is one eosinophil with the normal granules. They are like caviar, red caviar, but here you have this giant, giant granules. This is the Chediac Higashi syndrome, and it is maybe manifested with light skin, this silvery hair. They frequently complain of solar sensitivity. They have photophobia, of course, and the infections that involve mucous membrane, skin, and respiratory tract. Very common are neutropathies. Here you have a baby with silverish coloring of hair and skin and hypopigmentation. Unfortunately, most of the patients progress to lymphoproliferative syndrome associated with Epstein-Barr virus. Some infections with lymphohistiocytic infiltrates, fever, jaundice, hepatomegaly, lymphadenopathy, and pancytopenia. This is the manifestation of lymphoproliferative syndrome. The deficiency of complement and the associated disease are divided according to the part of the complement. You see in this complement 1, Q or R or C2, C4, they develop lupus, glomerulonephritis, and very often encapsulated bacterial infections. And all this you see they are repeated. The lack of properdin, if you remember the properdin they produce and make holes in the infected cells or so that ions and electrolytes enter here, water and ions enter the cell and it is lysed. And this lack is connected with the recurrent infection, severe meningococcal infection. In fact, the deficiency of complement very often gives meningococcal infections. Here is the hereditary angioedema, which is also connected with the defects of complement. There is a specific congenital deficiency of this inhibitor with recurrent episode of non-pruritic angioedema. This is an endoscopic view of normal larynx, and here you have absolutely closed because of swelling of the throat and closing the larynx. They may occur, these non-pruritic angioedema may last quite long, you see, three days, almost 3 days. They may occur spontaneously or after minor trauma, stress, or anxiety. And abdominal edema can cause acute abdominal pain. The edema of the upper airway can be life-threatening and may necessitate emergency tracheostomy. I see that in medical literature there are too much studies on hereditary angioedema. If you are interested, you can see more. Here you have quite a grown girl with a facial swelling during a hereditary angioedema attack. And the treatment of some words on treatment, specific treatment of complement deficiency. It is quite hard because there is no component replacement. Plasma transfusions has been used in some patients with C2 deficiency, factor H deficiency, or factor 1. When there is membrane cofactor protein deficiency, it is treated with renal transplantation because it is a membrane protein. And some of the patients with frequent episodes of angioedema, they respond to prophylactic use of an oral attenuated androgen like stanozol, zolol, or adanazole, which increases the serum concentration of this inhibitor, but it has too many complications, serious because of treatment with androgen for women, it is not beneficial. You have the adverse effects like masculinization. You may have growth arrest in boys and hepatitis, so their use is limited. And the last two slides, you know already some of the defects. So I give you here the most common, the distribution of all them. The biggest percentage is for common variable immune deficiency, and then you see come the EGA deficiency, IgG, immunoglobulin, Hex-Linked agammaglobulinemia, the Bruton agammaglobulinemia, neutropenia, and then smaller and smaller, all the other that we talked about, and some pearls. The last one, the primary immune deficiency disorder result in severe, recurrent, or unusual, we call them opportunistic infections, congenital neutropenia and other phagocyte defects typically present with infections in the first several months of life. The severe combined immunodeficiencies present within the first year of life, and antibody deficiency typically present after second half of the year, after 6 months of age, but they can present later after several years of age. The type and the location of the infections can help the diagnosis. So that is all for today, students. Uh, for the next Tuesday, I we will return to the usual time, 5:30, because today I didn't have a lecture with the Bulgarian students. They have their special fete tomorrow. So they asked me not to have the lecture today, but next Tuesday we should start at 5:30. Is it okay?
Yes, Professor, thank you.
Okay. Now I will do some correction of the last two lecture, and I will send them. I have the mail of Sotiris and Marco. So look for the lectures in Sotiris email and Marco.
I will share with the rest of the students.
Beg your pardon?
I will share the lecture. Thank
Okay,
you.
okay, Sotiris. Have a nice week. All
You
the
too,
best. Bye
Professor. Bye
bye.
bye.
Bye bye.
Nice evening.